COPH convening on Black health in New Mexico. I am Verlin Joseph. I am the chair of this committee. I'm also your MC for today. So first, I'd like to thank all of you for joining us today. I will say that we have a lot to cover today. This is going to be a jam-packed event, so we're just going to go ahead and jump right in and get started. What I will say is that we're going to be covering a lot of topics today. We're going to talk about gender, education, housing, history, art, all things that are related to health and the state of health for Black Americans in New Mexico. I will say at the onset that our goal here today isn't to provide a comprehensive review of all the issues that Black Americans are facing, but rather our goal is to really facilitate collaborations between everybody who's attending, right? So one thing we're going to be doing is we're going to be placing extended bios of all our presenters in the chat. So please look out for that. So if you have questions, also feel free to put them in the chat and direct them to the larger group, or feel free to use the chat to facilitate some of these collaborations as well. So with that being said, we're going to go ahead and jump right in. But I would like to start by reading the Land and Labor Acknowledgement, which is going to recognize Black Americans and respect Indigenous peoples as traditional stewards of this land and the enduring relationships that exist between Indigenous people and their traditional territories. So the Land, Labor, and Sacrifices of Black Americans Acknowledgement reads, at UNM, we respectfully acknowledge the traumatic history of forced labor of Black Americans who have advanced our country. We are indebted to the enslaved and exploited African Americans who established our US infrastructure and economy, advanced civil rights, and continue to influence popular culture. We are obligated to continuously recognize historic and current systemic oppression and injustices placed on Black Americans. We are grateful for their ancestors, for without them, we would not be where we are today. Thank you. Next, I would like to recognize by name, feel free to wave, all our DEIA committee members, starting with Dr. Alexis O'Donnell, Dr. Grace Chung, Dr. Claudia Diaz-Fuentes, Dr. Elena Kuhlmeyer, Dr. Elise Amarillo, Dr. Amber Dukes, Lillian Walker, Esperanza Wells, and Deanna Pereira, excuse me. Now I would like to, a couple more names, Dominique, Terreno, and Lena. Next, I would like to introduce our Associate Dean, Dr. Andrus. She is the Associate Dean and Associate Professor at COPH. She serves as an ex officio member of the COPH DEIA Committee and is also one of the college's representatives on the Health Science Center Inclusive Excellence Council. We'd like to acknowledge Dr. Dean Andrus as an assistant in creating and implementing these DEIA convenings. Dean Andrus.
Thank you very much, Dr. Joseph. It's a pleasure to see everyone today. I'm so glad to be involved in this event today. I do want to take a minute to recognize our students. Dr. Joseph called their names, but you guys just wave your hands. So there's Lillian, Esperanza, Diana, Lena. So they are our students. And then our staff representative is Dominique. And if she's out there, raise your hand, Dominique. I just wanted to call attention to them because they take extra time to participate in our COPH DEIA committee, and we're very grateful for that. Just to ground us in the chat, I just put the agenda so you know where we're driving today. So we have several presentations. We are premiering a documentary film from the New Mexico Black Leadership Council. Africana Studies has a panel that they will present. We have the Black Education Act of New Mexico. We're going to be covering infant and maternal health for women of color by Black Health New Mexico. Then we'll be looking at the state of Black collegiate mental health. And if you're still hanging in there with us, we're going to be looking at affordable housing for African Americans in New Mexico. Next, I want to invite comments from someone that we hold in high esteem here at UNM and especially in health sciences. And I'd like to turn it over to the Vice President and Executive DEI Officer for UNM Health Sciences, Dr. Valerie Romero-Leggett.
Hi, good afternoon, and thank you so much, Dr. Andres and Dr. Joseph and the committee and the students for really bringing us all together today, and also in all of the DEIA convenings that you put together, and really appreciate the thoughtfulness and the opportunity for us to continue to really be learning from each other and learning from communities, which I just think is so incredibly important here. So I'm again delighted to be here joining you today and representing our UNM Health and Health Sciences Office for Diversity, Equity, and Inclusion. And I just really appreciate how much we have shared values, right? Our collaboration together with College of Population Health is really deeply rooted in our shared commitment for inclusivity, diversity, equity, and social justice, both for health and healthcare for our state and globally, really. And I feel like when we talk about so many of the issues and things that we're going to learn about today and really also celebrate, but also, you know, come together to address so many of the inequities that we see both in health and healthcare in our communities and in the Black community specifically today. I just, again, appreciate that we have so many different voices here, and we're looking at so many of the issues that are really imperative. And unfortunately, so often, many of these, like, we continue to hear, right, over and over and over. But I truly believe, and I know that you and the committee and the College of Population Health believe that together and in unity is how we are going to make these changes. And again, appreciate the fact that we are all here together to do that. I know that we're also all very much aware of the repercussions of underrepresentation in our healthcare workforce, and really how this underscores the need for specific initiatives aimed at addressing these inequities. So again, I feel like today's DEI convening is a testament to the strength of community and partnerships and collective dedication to driving positive change. I appreciate the momentum starting last month's event focused on Native American and upcoming gatherings that will delve into other critical topics, such as the neurodivergent issues coming up in higher education and the Hispano-Latinx health and social issues convening as well. So again, grateful to the opportunity to collaborate and to learn from each other, and just feel that together we're going to continue our journey to achieve the inclusivity, the belonging, addressing these health disparities. And I'm looking forward to, again, continue to learn. I see many colleagues here and others that I'm very excited to continue learning from. But again, this is hard work and we do it together. So thank you, and appreciate the opportunity to get to be here with all of you today. And let us know if we can also be of any assistance to you. Thank you.
Thank you so much, Dr. Romero-Leggett. We really appreciate your participation today and the invitation to collaborate. We are really looking forward to doing more work with health sciences and your office. I want to take 1 minute now to introduce Dr. Harold Bailey. And he's going to deliver a few remarks. He's president of the Albuquerque NAACP and past director of UNM's Afro-American Studies program. Dr. Bailey, are you with us right now?
Yes, ma'am, I am. I don't have too much to say. It's a joy to be invited to this distinguished group. I'm here to learn, get educated. You know, we're all concerned about health disparities and the social determinants of health. So I'm mostly concerned about what strategies are we going to develop and design after we have this meeting here. So other than that, I'm just happy to be here, and most certainly I know I'll be educated. Thank you.
Turn it back over to Dr. Joseph.
Okay, thank you for those warm words. we will now move on to something I'm really excited about. So I want to introduce someone who likely doesn't really need an introduction, someone who's well known in the New Mexico community, Mrs. Catherine McGill. She's wore many hats, but I think one that she's most proud of is that she is the founder and the director of the New Mexico Black Leadership Council and the New Mexico Black History Organizing Committee. And she will show us a documentary film produced by herself, and I'll turn it over to her to expand and to present this film that we're really excited about.
Thank you so much, Dr. Joseph. And Dr. Andres, and it's really great to see you, Dr. Romero-Leggett and Dr. Bailey. All these doctors, I feel like I'm in such great company today, and that we do have the community's history on this call today. And so we, like Dr. Bailey said, are going to be able to do some things. The entire DEIA community, I appreciate you all, and I want to debut this film that we created with the support of a contract with Dr. Lisa Kakari Stone from the UNM Tree Center, and the support of the Department of Health Better Together initiative, Secretary Patrick Allen. So we are debuting the film here today. It's really not done. We have more things to add to it, but right now we want to use it to give us some information about the state of Black health in New Mexico pre, during, and post-pandemic. And I'm really excited that we're dedicating this film to 3 doctors whom I know, Dr. William McIver, who is retired and living with his family here still in New Mexico, and now 2 doctors who were great New Mexico doctors who are our ancestors, Dr. Robert Oscar Gathings and Dr. Eric Best. They really showed us how to care for a community, and so we honor them today. The film is about 9 minutes long, and I'll talk to you briefly on the other side.
$2 million.
This is a place of opportunity. Some people maybe call it the land of entrapment, but I call it the land of opportunity. I wanted to stay here, especially after residency training, was because the landscape, I mean, it was something about here that just felt like it was more in tune with just nature. And so it was that. The people were nice. I mean, they're treating you like an actual person and not maybe like any form of labels. So they're actually really trying to get to know you type of thing. The demographic is a little different here than where I've been trained. And first out the bat, there's not a lot of Black people here.
When my mother moved here, we said the Black population went up 25%. But in New Mexico, it's a bit different in that our population is so small, it's often invisible. And that's probably part of the problem here is that we tend to be a forgotten population.
When you think about the state of Black health in the United States, African Americans suffered from COVID at a disproportionately high rate. And I would suspect that you would find the same thing here in New Mexico if we were to dig down deeper. The African American population is generally working in lower wage jobs, and they were deemed needed. So when some of us could take off from work and shelter in place and work at home, they had to be out delivering your groceries. They had to be out working in other places that needed to be kept open. So I suspect some of that may have been happening here in New Mexico, but we just don't know. And until we find ways to talk with the African American community, literally go out and engage with them, then we're not going to be able to get a really good picture of what happened, I think, with African Americans in New Mexico with COVID.
You know, COVID-19, the SARS 2.0, and I call it that because the first SARS event, happened in 2003 in China, and they were prepared for it, so they had facilities and things built up to manage it. We were asleep at the switch with this. In fact, in 2014, and looking at some of the data and some of the trends, I tried to tell the folks here in New Mexico that we need to start doing better surveillance and doing things, putting monies to get ahead of the curve on this. Nobody paid attention. Many of the disease conditions that people suffer from right now, the chronic disease conditions, disease of lifestyle, don't happen when all of a sudden somebody's an adult. These are things that start in childhood.
What we see is that, unfortunately, there are a disproportionate number of African Americans that have comorbidities, hypertension, diabetes, asthma, obesity, things that were poor prognostic indicators for how well a person would do with COVID. And I think one of the things that we saw with deaths in the African American community were not only related to lack of access to care, but getting care late, sort of having a mistrust of the medical system because of past practices, whether that's discrimination or experimentation in this country. So I think what happened during the COVID pandemic is what we saw was COVID became politicized.
The issue is one of excess capitalism. Since you can make more profit on people being sick than you can on people being well. Although, if you understand prevention and public health, you begin to understand that if you have a healthy population, then you have a healthy economy. It brings to mind the reason why we have to talk about health equity. Because when we talk about COVID-19, one of the things that we talked about, at least in some parts of the country, in some places, was that equity is the only thing that's going to flatten the curve. We suffer from prevention deficit disorder. So everything that you saw on TV, basically, for the most part, or people, the pundits and people are talking about, was really always from the perspective of medicine and treatment and not prevention. Obviously, those pre-existing conditions are the things that would worsen a person's immunological status to a unique virus when it came down the pipeline.
When it comes to how to change that, there has to be support from the entire community, regardless of what you look like. It's not something that you can just say that, oh, that's your problem and you deal with it. No, it's going to be everyone's problem. This impacts everybody. How can we reduce these health outcomes in a non-pharmaceutical way?
So we're talking about upstream factors. What are upstream factors? What needs to happen to organize and to get better health outcomes for African Americans in New Mexico? Well, these upstream factors are things like, where do African Americans reside? Where are opportunities for healthy, affordable food that they can have access to? What does the transportation system look like across New Mexico?
Where you live, work, play, and go to school has more of an impact on your health than your genes.
So there are many things that we can do to improve the health of the whole country that in turn would affect the health of African Americans within this country just by default.
Biases exist, they're going to exist, and what we need to do is put in processes to take that out of the equation as much as possible. There was an interesting study with lung cancer and the time from diagnosis of lung cancer to getting surgery for that cancer. And there was a bigger gap for Black patients. And so what this study did was, rather than trying to go in and talk to providers and say, you're being biased, blah, 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 all these things, they said, let's just fix the process and put in things that take the human part out of the equation. And what they found was that the percentage of people getting surgery on time went up for both groups, and the disparity disappeared completely. But it takes institutions taking the time and the effort to look at their processes and fix those. And this is one of those situations of someone trying to build a plane while it's flying. they're so busy with everything else, it's hard to get institutions to stop and fix an entire process. But that is part of the work I think needs to be done.
How much better would the health be if everyone could get to a grocery store with affordable, healthy food? If everyone could actually earn a proper living? You know, it's complicated, right? It's complicated, and all communities, even within New Mexico, are not the same. Many people who live here are not from here. And so you truly have an African diaspora here, right? And so I think having a thorough survey, being thoughtful and really critical are going to be key. So I think those are the things that we need to address.
It's going to take a revolution of consciousness. So we need more stories. I think there is a tremendous need to really improve this phenomenon known as health literacy. Our biggest enemies are fear, doubt, ignorance, superstition, apathy, and irreverence. And the only way we're going to overcome that is to establish truth, justice, mercy, and compassion.
I want to thank you guys so much for watching the film. And there is in the chat, I put a link to the survey that we'd love for you all to take and help us get some more of that information that we're looking for, because we know that the absence of the data, the absence of infrastructure is in and of itself a disparity. So what we're hoping is that we can view this film as a marker in history. We know that in many ways that among all of you, we're preaching to the choir. We're looking for some converts on the outside of this choir and people who understand that we do need to look at more equity in the way that we are collecting data, that we need digital literacy and people understanding technologies and emerging technologies. We need to be able to have policy advocacy and collaboration. And so those are the things that I hope this film will give us some ability to invoke some civic dialogue around these important issues. It's not the end of the story. It's the beginning of what Dr. Bailey said, is that we want to see now, after we have this event today, what we're going to do. I want to end by thanking Dr. Lori Andres, Dr. Jamal Martin, Dr. Dwayne Ross, Dr. Vanessa Alderashida, and Dr. Stephanie Garcia for being in the film. It was my great honor to work with them. I hope we can continue to work with them. I hope to work with all of you. We have much more to do. And I always leave with my favorite quote from James Baldwin, who said that not everything that is faced can be changed, but nothing can be changed until it's faced. Let's do that today. Thank you.
Thank you. That was an excellent film. Can't wait to see the full feature-length production. That was amazing. It's also great to see some of our colleagues as well participating in this. You summed it up great. I'd just like to say, I think we really were able to see in that film some potential avenues that we can build collaborations, improve health literacy. Like I like the quote where we're building a plane while we're flying, right? So I think we can identify some of these ways that we can address all of the mixed populations, including especially the Black population. As we know, at times we can feel as though we're invisible. So thank you for highlighting that. That was excellent production. So next, quick housekeeping. I forgot to mention at the beginning. Please, if you have questions for our presenters, please place them in the chat. We will try our best to designate some time at the end to facilitate a Q&A back and forth. But for the time being, if you can place your questions for the presenters in the chat, and if you're able to address them maybe after your talk, that would be great as well. But if you're unable to hang out until the very end. So we'll do that, facilitate the discussion that way. So thank you.
And Dr. Joseph, I reposted the link that Catherine gave us for an evaluation or a survey. So please take a minute, everybody, copy and paste that and put it into your email or something so that you can participate in that survey. Thanks.
Okay, thank you. So next, we're going to move on to our Africana Studies panel. We have 3 esteemed speakers. I think we're really fortunate to have. I sort of just want to say I was fortunate in some ways, other ways not so much, to grow up in New York City, right? And to be around some of the amazing Black scholars that we know, like the Dr. John Henrik Clarks, et cetera. And a lot of the work that's going on here with this Africana Studies group is just amazing and next level. So it's my great pleasure to introduce our next speakers for the Africana Studies panel, Dr. Buick, who's the Professor of Arts, History, and the Chair of Africana Studies Department, Dr. Jamal Martin, and someone who I owe several emails to, Dr. Kathy Powers. Dr. Jamal Martin, he's also a professor in Africana Studies. Dr. Kathy Powers, she's an associate professor of political science in Africana Studies as well. I will turn it over to you all. You have roughly 50 minutes. I'll give you a little warning about when you're getting close to your time, but I'll turn it over to you now. Thank you for being with us.
Thank you. Thank you for having us. Thank you, Dr. Andres, Dr. Joseph. It's an honor to be here today. I am going to start sharing my screen. Let's see. So as an art historian, one of the things that I study is the history of medicine, because medicine is yet another way to represent the body and our expectations of that body. Let me see there. So just want to speak briefly, and I'm starting my timer so I don't go over. Medical representations of Blackness, the politics of pain. So how does the medical profession construct and enforce stereotype through the treatment of the body? That's the kind of organizing question that I chose to tackle today. Arthur Kleinman, who is a medical anthropologist, understands that suffering encompasses the individual level, but also transcends it as cultural representation, as personal experience, and as the embodiment of collective memory. Suffering is ultimately social. Kleinman goes on to argue that social suffering, its relation to subjectivity, its bodyliness, I'm not going to be able to say that this afternoon, as processes that connect the moral to the medical, a bodily process that connects the moral to the medical, the political to the emotional, and the religious to the physiological, and the manner in which it, and with it, the human experience of transformation is being remade in our disordering contemporary world. So pain, what is it? From the Greek word, poena, meaning retribution. From Middle English, suffering inflicted as punishment for an offense. Pain, as we commonly understand it today, though, is physical suffering or discomfort caused by illness or injury. And yet those very ancient ways of imagining pain also encompass the Black experience. Our pain culturally, historically, has been thought to be different. The next is a quote I'd like to read to you from Dr. Ava S. Hayward. How do you describe pain? Pain is voided language, not more than language, but its absence. The anguish we describe to pain is a demand for language out of pain's meaninglessness, out of the obliteration that is pain. And so very briefly, the politics of pain. There is a history to perceptions of Black people's ability to experience pain, but it comes primarily from the epidermalization of race, right? The idea that race is not just a skin, but it's deeper than skin. And I'd like to take you all the way back to 1851 and the idea of diaesthesia aethiopsis or a diaesthesia aethiopica, nursing 101, and then the impenetrability of Black skin. So in psychiatry, diaesthesia aethiopica, literally Ethiopian bad feeling or black bad feeling, was an alleged mental illness described by American physician Samuel Cartwright in 1851, which proposed a theory for the cause of laziness among the enslaved. Applied exclusively to African Americans, diaesthesia aethiopica, called rascality by the overseers, was characterized by partial insensitivity of the skin, and so a great hebetude of the intellectual faculties as to be like a person half asleep. Other symptoms included lesions of the body discoverable to the medical observer, which are always present and sufficient to account for the symptoms. Cartwright contended that the existence of diaesthesia aethiopica was clearly established by the most direct and positive testimony, but other doctors had failed to notice it because their attention had not been sufficiently directed to the maladies of the Negro race. Cartwright felt that diaesthesia aethiopica was easily curable if treated on sound physiological principles. Insensitivity of the skin was one symptom of the disease, so the skin should be stimulated. But just to skip down, he said, Cartwright says that after the prescribed course of treatment, the slave will look grateful and thankful to the white man whose compulsory power has restored his sensation and dispelled the mist that clouded his intellect. According to Cartwright, diaesthesia aethiopica was much more prevalent among free Negroes living in clusters by themselves than among slaves on our plantations, and attacks only such slaves as live like free Negroes in regard to diet, drinks, exercise, etc. Nearly all free Negroes are more or less afflicted with it, that have not got some white person to direct and to take care of them. He explicitly dismissed the opinion which assigned the causes of the problematic behavior of the social situation of slaves without further justification. The Northern physicians ignorantly attribute the symptoms to the debasing influence of slavery on the mind. These ideas about enslaved peoples or Black people's insensitivity to pain translated to how we taught our children to play. On the left, you see a doll. It's made out of black rubber. And these dolls were sold as the analog to the white porcelain doll that was precious and to be cared for. But these dolls were sold to be beaten and thrown and tortured and hugged. Southern doctors claim that people of African descent carried a hereditary disease called diaesthesia aethiopsis, or an obtuse sensibility of body that rendered Black people invulnerable to corporal punishment. It is ultimately the ideology that is the source of our oppressions. Racism constructs and maintains race. Nationalism constructs and maintains nation. It is sexism that constructs and maintains gender, all as fixed, discrete entities and identities that cannot do justice to the complexities of our embodied and lived experiences, but that work to make us legible to the state and targets of exploitation or recipients of power. The function of racial ideology is that it explains the exclusion of some people from the ideology of freedom and liberty, perceived as a natural right extended only to some. Ultimately, it ameliorates class conflict, but it also explains the exploitation of people who are deemed inferior because they have race. And emphasis here on the individual as at fault for having that race or having that gender. And it hides the systemic origins of exploitation. Racism is ultimately a producer of difference. Racism is the producer of difference rather than a product of difference. Just as sexism constructs and maintains and polices gender, and nationalism constructs and maintains and polices nation, racism constructs, maintains, and polices race. It is a category of practice that, as Black people who have to submit to the medical profession, often to our detriment. And Race Thinking 2014 to 2022, most of you are probably familiar with this Pearson textbook on nursing and bioethics titled Nursing: A Concept-Based Approach to Learning, Volume 1. A new edition was finally published in 2022, and hopefully they removed this section on focus on diversity and culture, cultural differences in response to pain. Black people are, they were taught, nursing students were taught, often report higher pain intensity than other cultures, meaning that Black people exaggerate their pain. They believe suffering and pain are inevitable. They believe in prayer and laying on of hands to heal pain, and believe that relief is proportional to faith. And so in this rubric, Black people are liars. We exaggerate about our levels of pain. And so if you're given a scale on which to name your pain as an 8 or a 9, you may be treated with a pain level of 5 because these students have been taught not to believe us. And you can see how they categorize Jews may be vocal and demanding of assistance. They believe that pain must be shared and validated by others. All of these racist stereotypes that now predicate and predict the levels of treatment based on perceived race or ethnicity. And this is just a little bit, and I'd be happy to share the PowerPoint to anyone who's interested, because I don't want to go over time, but you can see the article from the New York Post in 2017 calling out this textbook. Hispanics may believe that pain is a form of punishment and suffering must be endured if they are to enter heaven. I mean, these kinds of ways of taking the stereotype and then treating accordingly. And then there was this tweet from October 31st, 2022. A nurse commented that Black skin is definitely thicker than white. I'm a nurse and give injections every day. You can feel the difference as the needle goes in. This is also why Black people age way better. And the response to this by this young man saying, you know, to anyone who says that racism in medicine doesn't exist, look no further. And then the responses are in themselves interesting. This is why I have so many issues with nurses. This isn't a nurse-specific issue, someone replied, and that wasn't the purpose of the tweet. Any healthcare professional can harbor these types of biases, which is certainly true. But as the next person says, an attempt to kind of absolve the nurse, it sounds more like naivete than racism. Is there a negative connotation with what she's saying? Absolutely. Absolutely. She may jab a little bit harder to penetrate Black skin. She may rank the attestations of pain by a Black person lower than what is actually expressed. And as this next person responds, she's a medical professional. Naivete can kill people in their industry, which is why Black women die at far higher rates during childbirth than I'm not sure other women is perhaps what was meant to be expressed. And so that is just a brief and dirty history of the medical profession and the kind of ambivalence around pain. Pain is a kind of registered response to illness or injury, but in the case of racism, pain as retribution. It still sadly calls back to those old understandings of pain. And I'll stop there. Thank you.
Thank you so much, Dr. Buick. We are recording this and slides will be made available.
Right.
That was a tremendous presentation, a lot to think about. Dr. Joseph, you want to move us to the next presentation?
Yes, is Dr. Martin?
Yes.
Here. Hello?
Yes, Dr. Martin, we can hear you. Are you?
Can you hear me? Okay. Good. Good afternoon, everyone. Thank you for inviting me to this important forum. I was going to show some slides, but I have like 5 different sets of slides I made for this, so I'm not going to use them because it's starting to turn into a book chapter. But my purpose in this forum is to advise and advocate for improvements in public health, welfare, safety, and morals and government power, and with systems transformation in the basis of government as dictated by an examination of the political determinants of health equity. So let me start by saying this. First of all, this is Black History Month. And so concerns about Black health and social issues in New Mexico generates a memory about the scholarship of Carter G. Woodson in particular, you know, a historian, author, and educator. And I'm referring specifically to his book, The Miseducation of the Negro, published in 1933, which warns and advises African descent people about the pitfalls of exposure to a hegemonic slave master system which supports structural violence, in that it benefits—
Dr. Martin, do you know your camera's not on?
Well, it will be in a moment. How's that?
Thank you. Perfect. Okay.
At any rate, I'm thinking people are tired of seeing my face and my voice anyway, but that's another story. Anyway, he talks about the system that supports structural violence and that it benefits the dominant Eurocentric American culture and disadvantages the culture of African descent people. While time does not allow me to really go into the integrationist, separatist, and pluralistic perspectives about the social political thought and educational philosophy deliberations, the point remains that the misuse of an institutional educational system and its approach in dominating the thinking and actions of its adherents results in systemic harms to health and human development. Human development is undermined by degradation, dehumanization, subordination, and misrepresentation of African descent people, particularly when this relates to human health and security. While rarely stated in aloud in public policy settings, the infamous idea in New Mexico of the tricultural state model remains embodied in the sub or unconscious deliberations about power, independent and dependent variables, and their relations to causality, including key mediators to Black population morbidity and mortality. So public health information necessary to advance health equity through community engagement remains stifled under betrayal trauma. The broken promises and failures of reconstruction within the political rise of the lost cause have inured or hardened many opportunities to flatten the disease curve. Therefore, rises in syndemics, multiple medical conditions, threaten an African-centered culture of health, especially when emerging infectious diseases conditions expose risk factors towards excess death rates. Moreover, Eurocentric formation of health sciences professional education, as favored by mainstream advocates, really furthers epistemic apartheid within the tacit, explicit, and implicit ways of knowledge production. This is why I'm now in Africana studies. Only epistemic disobedience can improve health outcomes for African descent people. So when we talk about political determinants of health, I want people to understand that health law is a keystone framework for eliminating health inequities. And so public attention is a necessary ingredient in this opportunity to figure out how we have discourse about the systemic institutional racism and white supremacy that exists. And I think that through reliance on African consciousness and methods, our community action, community engagement, and participatory parity can rescue us from the harms of the African Holocaust. So it's important to remember that education is the most robust predictive health status. So in essence, we must end epistemic apartheid in health science professional education. When you look at New Mexico and you see that the issues of that are most important for understanding health status and reducing syndemic conditions are infant mortality rate, life expectancy, maternal morbidity conditions. And recently, the BRF, the Behavioral Risk Factor Survey, has shown that pre-pandemic and post-pandemic, we've seen greater prevalence and incidence of suicide ideation attempts and fear of gun violence among Black school-age children. This is unacceptable. So I think that if we want to really understand how to improve health status conditions in this country, we have to understand tools such as the health risk, quality of life, years productive life loss, quality of adjusted life years, to better interpret functional health status across the lifespan. Now, let me explain what structural violence is, because that's a new term for a lot of people. When I talk about structural violence, I'm really talking about disparities, disabilities, deaths that result when systems, institutions, policies, or cultural beliefs meet some people's human needs and human rights at the expense of others. Structural violence creates relationships that can cause secondary violence to occur. Examples of secondary violence are self-destruction, alcohol abuse, drug abuse, suicide, depression, internalized oppression, community destruction, crime, interpersonal violence, domestic violence, rape. And then there's national and international destruction, which are rebel movements, terrorism, suicide, civil wars, revolutions, coups, and wars. And these are reactions and responses to structural violence. So when we talk about structural violence, we have to really sort of think about the political determinants of health in relation to structural violence. And sometimes, we don't notice them but our nation's history is built on the underlying structural racism, misogyny, and other forms of unconscionable discrimination. Our journey to health equity really begins with understanding how the political determinants of health are rooted in the Constitution and conflicts over power between the branches of federal and state government, and the ongoing polarization and conflict that exists in the two-party system, not to mention the capitalist biases, being the main drivers of inequality. Anybody who's had one case in law, you've ever watched a TV show, you know that the phrase stare decisis, the precedents, let the decision stand. So when we talk about political determinants of health, we're talking about systematic processes of structuring relationships, the distribution of resources, and the administration of power, and how they simultaneously operate in ways to shape opportunities that advance health equities or exacerbate health inequities. This is a lot to bite on, but we need to think about this. When we think about political determinants of health, there are three things to keep in mind: voting, government, and its value for investment, and policies that exist for equity and inequities. So when we look at discrimination, we have to think about the structural, the institutional, the interpersonal, and the intrapersonal. And all we can do at some points is ask professionals and others in the community is to be advocates for due diligence, by asking these questions. Is the health outcome systemic or systematic? Is it avoidable? Is it unjust? And then proceed in ways of negotiation, understanding ways to negotiate, ways for introspection, and ways for bringing about direct action. It's important to remember that after the Civil War, freed people were the first to lobby for health equity and health care. And we seem to have forgotten that in some ways as we get around from those political things. And so we're still dealing with the pathologies of power and place and the privileges associated with whiteness and the disadvantages of color, which are, looking at these forms of oppression characterized as both process and outcomes, and they're rooted in the ideology of inferiority. They're long-term, they're consistent with the economic, social, and political inequities based upon the myth of the live race. And so with institutionalized racism, these patterns of procedures and practices and policies within an organization that penalize and disadvantage and exploit individuals, they are also organizational procedures, such as hiring and promotion and evaluation, which is important for DEI, and how that affects recruitment and promotion, and the organizational climate, which is staff member attitudes, beliefs, and behaviors, internal climate, policies and procedures, and the influence of communities that get involved in this in terms of public policies things. So we've done a lot of work in the past at this university in terms of understanding implicit bias and other types of wings and looking for cultural competency or cultural humility, but they've been somewhat not as effective as they should be. But context matters in terms of freedom and literacy, because that's what people of African descent have always wanted since being captured and enslaved in this country: freedom and literacy. So I think that we have to think about the web of causation or the network of those dynamic multi-causal associations and the need for multiple levels of analysis as we interconnect systems and have these as we decolonize these political ideologies, environmental factors, and social environment. So we have to look at the context of governance, macroeconomic policies, social policies, public policies, the culture and societal values, and recognize that the key informers of data for freedom ratings are about political rights: elected rule, competitive parties or political groupings, oppositions with actual power, self-government or minoritized groups or their participation in the government, and then civil liberties: freedom of expression, assembly, association, education, and religion, system of rule of law, freedom economic activities or free economic activities, equality of opportunities. And as we roll through this, we'll see that as we talk about the social and cultural political identity of trauma and mass violence conducted against people of African descent, we have to think about more optimal ways for healing and resiliency. And there's a lot to be said about that in terms of the mental health issues and things at that level also too. Not to mention, the issues of across the life course trajectory and adverse childhood experiences and historical trauma and embodiment. You know, when we look at this, we see that African descent people are socially dislocated from their culture and values. But what we have are these emotional contagions that are related to the legacy of the slave health deficit, scientific racism, negrophobia and pigmentocracy, anti-Blackness in the modern world, de jure and de facto segregation, structural violence, stigmas and institutionalized behaviors, menticide due to the education system, post-traumatic slave syndrome, dysfunction and disorder. So these stressors, these traumatic stressors lead to the buildup of the wear and tear in bodies in terms of allostasis and weathering impact, and how that may have some impact on epigenetics and effects of those influence or gene expression, which accelerates aging because of stressors. I have about 5 minutes left, so I know that we need to talk about the paradigms of social epidemiologists, you know, thinking more concretely about epi plus demos plus crassy, thinking about eco-social approaches over the life course, embodiment, pathways of embodiment, cumulative interplays, the accountability and agencies, and how that connects with the political determinants of health. And I think that as we think about better health faster for all, we have to really sort of transform our public health systems and services through health justice, you know, access to evidence and expertise in designing legal solutions, helping engaging communities and building political will, support for enforcing and defining legal solutions, policy surveillance and evaluation. And last but not least, I'm going to say that we have to turn our attention back to Public Law 111-148, also known as the Patient Protection and Affordable Care Act, ACA, or Obamacare. And most of our attention in this country has been around the first few titles that dealt with insurance. But titles 4 and 5 deal with prevention of chronic disease and improving public health and healthcare workforce. And what that bill does is supply a lot of money and training and opportunities for reconstructing a new paradigm for getting rid of prevention deficit disorder. And so that's one of the things as we think about collective governance and the critiques from Africology, how do we really sort of create this epistemic disobedience to get rid of epistemic apartheid so that Africology, Africana studies, becomes part of our work of understanding and building a culture of health. So, you know, that's pretty much where I want to go with this today. There's lots more to be said with this. And like I said, I started off with about 6 different PowerPoint projections, slides for this, and it started turning into a book chapter, which I have to do in a few months, or in a few days. So I want to thank you for listening to me and putting up with me. And if you have any questions, please put them in the chat room or send them to me directly to Africana Studies. Thank you very much.
Thank you, Dr. Martin. We'll move to Dr. Powers now.
Hi, everyone. How are you doing? Can you hear me?
Yes, we can.
And can you see my presentation?
Yes.
Okay, so I have to make a lot happen also in 14 minutes. First, I'd like to thank Dr. Andrus and Dr. Joseph for the opportunity to be here. Dr. Buick and Dr. Martin, the Africana Studies faculty, and everyone who took the time to be with us today. So my job is to continue participate in a conversation about reparations for Black New Mexicans. And I'm going to start off first just broadly with what are reparations today and how do we think about it, although Black reparations in the United States precedes laws that exist today by hundreds of years and also are being influenced by them. Then I'll talk a little bit about the cutting edge of African-American reparations today, which is in cities and states in the United States, using city-level legislation, for example, health-related reparations, and then a couple things to think about for considering reparations for Black New Mexicans, which can connect to the national effort, but is also quite unique. It starts the conversation, which means you need to bring me back to just focus on this idea of how do we think about it in the unique context of Black Americans in New Mexico. The first thing I want to do whenever I give a reparations presentation is I recognize this family whose son, Sam Brown, in the middle picture was a student of mine 25 years ago and asked a really simple question to a trade scholar. Why did my African-American grandmother not get reparations for slavery, but my Jewish grandmother did for the Holocaust? And that simple student question changed my world. He's there with his son who came to office hours back then. And there's family suffering and the profound questions that came from that and my own family sent me on this quest. So what are reparations? This is an international legal definition today under the United Nations Right to Remedy in 2005, which says that as a function of being human and having human rights as articulated under international human rights law, there's a legal obligation to address the harm, violations of human rights that have happened. So it says that as a function of being human, which there's so much to talk about, who has the power to define that, and your human rights are violated, you have a right to reparations, and that your country's government has a responsibility to provide for them, whether or not your government is directly responsible. And I put in the presentation a direct excerpt from this United Nations General Assembly resolution so that you can read it. So please post my slides. And these are the functions of reparations that are articulated that we generally see, although in my work I found others. So restitution is to restore that which was taken away. Exactly. If your vote was taken away, to return it. If your land taken away, to return it. And that's restitution, to restore what was taken. Compensation is the stereotypical way that we think about reparations in the West and in the US in particular, as money and compensation for that which cannot be restored or replaced. For example, the loss of loved ones or the impact of historical injustices over the experience of Black people in the United States that's compounding and systematic and continuous across a range of issue areas. Rehabilitation is the cutting edge of reparations today, which is where health falls in. What are the psychological consequences and harms, the physical harms, and how do we craft more creatively and directly reparations that get to those harms? The Global South leads the world and thinking about if you have a constellation of harms that affect you psychologically and physically, as in Peru, community health centers that offer free health care for victims of human rights violations. CARICOM in the Caribbean and its 10 points articulates a requirement that all reparations for slavery should include rehabilitation. Satisfaction is to give voice, and that could be a form of reparations or returning the bones of loved ones that have been taken. And finally, non-repetition, the promise to not do it again. I'm sorry, I'm making sure I can see my timer. So what are the things that can perform as reparations? The African-American reparations debate, which African-American is contested today, whether or not, who does that include and if that term is appropriate. Can be money as we think about in kind. So natural resources in World War II taken from Germany, given to the Soviet Union were reparations. People can be reparations. Nazis were sent to Siberia as reparations to the Soviet Union when Germany had nothing left to give. And their descendants still haven't made it back to Germany. Prosthetics can be reparations in Sierra Leone. If your hands and your feet were cut off so you can't work or vote, prosthetics can be reparations to repair the direct harm or at least address it. Healthcare in general, memorials for memorialization, education, and economic development. I wanted to just give you a sense of today, the norm globally, and even now happening in the United States, is mechanisms of reparations that are used. It's a portfolio. Educational benefits, monetary compensation, and medical care tend to be a standard component of reparations policies when it's a public policy across the planet, and is now happening in African-American reparations. So issues to consider in African-American reparations. And why do I have it in quotes? The American descendants of slavery currently have sort of a leadership role in the discourse on reparations, which is why we see so much at the city level, who have used the word Black Americans, excluded people of immigrant descent from the Caribbean and the African continent, requiring that you have one parent who's a direct descendant, oops, I'm sorry, who's a direct descendant of an enslaved African in the United States. So we've seen the Pan-African movement, African-American reparations, Black American reparations. We see even the Caribbean, CARICOM, only including English-speaking countries, but leaving out Haiti and African Americans. So who has the power to decide? Who has the power to decide? Who is defined as being included? Has led to some exclusionary measures that are contentious in the community today. So what are some of the issues? That's one. Who has the power to decide who can be included and not? Who defines who is human? Who is a citizen? Who has the power to decide who has the power to decide? Who has the right to seek repair for harm in the form of reparations? And where can you seek it? Is it at the city level, the state level, in legislatures? Is it in courts? Is it in international courts? African countries led the United Nations Human Rights Council in voting for resolutions unanimously by all 47 countries who are party, that the United States must create a truth commission and reparations to deal with police brutality in the United States towards people of African descent. Who has the right to seek repair from harm and in the form of reparations, and where? Who should be held accountable for violence and murder over the question of reparations? People will fight, kill, and die over it. It has not happened in our community, but if we're not careful about who we include and exclude, it could happen. Social movements and the demand for reparations, where do they begin? And where are African American efforts generally centered in the United States do not follow global trends. Why? Because the United States, from a global, local, historical perspective, we sit inside a global hegemon, a militarily and economically powerful country that is a permanent member of the Security Council, has signed on to the International Criminal Court, but can't be held accountable, has not signed on to it, but can send cases that way. African Americans are different than people who demand reparations on the African continent and in the Caribbean because we don't control the apparatus of the state. Dr. Belinda Wallace at UNM is someone who pointed this out to me and has had a profound impact on how I think about the spaces where we have legal rights, legal standing to pursue. And that's why in the African American case, it's gone the opposite direction of the rest of the world, down to the city level, where in cities with large Black populations, you can have an impact on city level legislation that is passed, as opposed to going to new regional human rights courts that exist today that allow individuals to bring claims against their own governments. We have over 250 years of human rights violations, systematic police brutality over the course of the presence of our community since the moment we got here. It has been systematic, continuous, across a range of issue areas, which means that there's no singular movement. There are different efforts. Some are legal claims, some are public policies, some are led by community organizations, by individuals. HR 40 in Congress has been an effort. And so it is a constellation of efforts, which is why we have to think about it as a collection of movements over 250 years. This just kind of gives you an idea of the spaces in which it's happening in state legislatures, national legislatures, cities, corporate claims, community-led, the NAACP and COBRA, Black Lives Matter, and ADOS, universities that are confronting their past and laws and ordinances that we're seeing at the state and city level. So where's the cutting edge of African American or Black reparations today, which is important for Black New Mexicans to consider at the city level and at the state level? It is a contemporary venue for reparations in opposition to what's happening globally, and it's at the local level where we have more influence. This is a picture of Councilman Kenyon McDuffie of Washington, D.C., making a speech arguing that there should be reparations for African American, he used the term residents. Mayor Elorza of Providence, Rhode Island, just signed legislation to enact reparations for the role of Providence in being a slave port for slave ships that came to the United States. These are our reparations entrepreneurs, leaders who are leading the movement in different ways on different issues. Representative John Conyers, for 30 years, introduced HR 40 to call for a truth commission in the study of reparations in Congress. It wasn't until George Floyd was murdered that Sheila Jackson Lee was able to pick up the mantle, start the conversation, and actually have hearings, although it hasn't been taken to a vote. I won't go through the tables that I have in here. I wanted to give you examples of cities who have already passed legislation or considering legislation that has been written. And this is not complete, it's just examples. Asheville, North Carolina, Evanston, Illinois, Providence. We have states like New York, California, and Texas. And these are examples at the state level. California State Representative Shirley Weber, Pennsylvania State Representative Chris Rabb. What they are advocating for, and the language is different in every city depending on the organization that's leading it. In LA and California and the state of California, the language is African Americans with particular emphasis on Black Americans. Other cities like Evanston don't distinguish. Elites have captured the process in different places. In Evanston, you could not participate if you were not 18 in 1969, which meant that only people from very old Black families could participate. These are examples of state level ones. What are health-related reparations? And I'll say this and stop here. I've lost track of where. Okay, I've got 33 seconds. This is an example of rehabilitative functions of reparations that can address, repair, heal, manage physical and mental consequences of human rights violations, like life-saving medical measures, therapy, medication. Healthcare systems and institutions created or transformed can be a function of reparations. We've seen this in the Chicago police torture case, where there is an extensive portfolio of reparations that has a significant health component. For example, issues we need to consider is not just the population served, and I'll kind of end with this, but the social change makers and community activists, where our mind, our spirit, our body is impacted not only by being part of our legacy, but sharing the trauma with others. I end with, and I'll leave it for all of you to see, what do we have to think about in New Mexico? The uniqueness of the experience, coming into the union later, and that people were already here who had assets, who lived here, who is a Black New Mexican and who isn't, and who has the power to decide. Thank you.
Thank you very much. I'd like to recognize the Africana panel and just say that they brought to us a set of issues that we don't often think about when we're in the health arena, but they are very important. And we can witness this from our discussion on the non-medical determinants of health that we have had over the last 12 to 15 years in the United States. But we wanted to make sure that these kinds of issues, reparations, harm, political determinants of health, Black representations of the body are on the agenda when we start thinking about health and wellness for African Americans. I do want to point out that we're running behind. We think we can make up time. So we want to ask that the other presenters watch the chat. We're going to put time stops in the chat. We do not have music to play you off. So if everybody will just be aware of the time. And Dr. Joseph, you want to introduce the next panel?
Yes, and again, thank you so much, the Africana Studies Group. I'll tell you, I've had many conversations in passing that I thought were going to be high and by, and we spoke for hours. So really happy to have them to be a part of this conversation today. Next, I'd like to introduce a three-member panel from the New Mexico Public Education Department, Identity, Equity, and Transformation Division. So we'll hear today from Kimberly York, Michael Batty, and Joseph Ulibarri. Feel free to start when you're ready. Thank you so much.
Thank you. And I do also have my timer going. First and foremost, thank you all so much for the inclusion of the Black Education Act in this very, very critical conversation. I think that it's very timely, and we want to thank you all for the opportunity to present our information. And I just want to start with this quote that that is the leading philosophy that we have with regards to the work that we do with the Black Education Act. And that is, preservation of one's own culture does not require contempt or disrespect for other cultures. That is how we ground ourselves and try to avoid getting into unnecessary distracting conversations by those that try to deter or don't believe in the work that we do. And that's okay that they don't believe in that, but we know that it is very important. And so I would first and foremost like to introduce my colleagues, Michael Beatty, who serves as our professional learning coordinator, and Joseph Ulibarri, who serves as our curriculum coordinator. We do have another person who just started with us that is serving in the capacity as our family and community engagement coordinator. I want to give honor where honor is due and say to you that while the Black Education Act is housed under the New Mexico Public Education Department, the work, the long-standing work to get this passed was the impetus was fell in the lap of the State Office of African American Affairs. And so I just want to give honor where honor is due. And we also want to say thank you because our sponsors of this, the House Bill 43, which is the Black Education Act, is Senator Pope and former Representative Cheryl Williams Stapleton. And so we are the fourth and final act in Education Act in New Mexico. It was passed during the regular session, legislative session in 2021, and Governor Lujan Grisham signed it into law on April 5th, and it went into effect on July 1st. I'm going to just give you a very high level overview of this chart because it just kind of tells you when we're fully staffed, this is who our team is. I do want to just point to two of the two orange boxes on the side next to the black boxes. So we are guided by a very robust and strong advisory council. That was the first charge that was undertaken back in December of 2021. And so we also have an anti-racism and an anti-oppression portal, which was a part of the mandate as well. And so those two entities, while the budget for the portal comes out of our budget, it is overseen by another bureau. So that's just very important to mention. So I'm going to just very quickly explain who we serve, and we'll get into some of the mandates of the statute itself. So we serve obviously pre-K through 12th grade. We also work very collaboratively with higher education. We have the privilege of having Dr. Patricia Trujillo, who is the acting Secretary of Higher Education, on our advisory council. We also work with parents, students, as well as community serving organizations like yourselves. Again, some of the key mandates. So I'm just going to very briefly tell you all that our council, again, is very robust. We have people who represent all walks of nature and all walks of life throughout New Mexico. We have a broad representation of higher education, both as well as K-12 and charter schools. We also have parents that are on our advisory council. We have a representative from the State Office of African American Affairs, as well as someone with the Disabilities Council. And so we are currently looking for additional parents and students that can serve on our council. And again, I'm not going to read all of these, but just to give you a very, very high level overview, what the council is charged with primarily is advising the secretary on best practices and promising strategies and those kinds of things that directly impact Black students. Our overall charge of the Black Education Act is to improve the educational outcomes in a very holistic way, but we do proudly serve all students. And so our council again, represents a wide range of professionals as well as lay people throughout the state that can advise us who are the boots on the ground in their community that can help us have a pulse on different and unique needs in different communities. They also help and assist us with white papers and information about best practices when it comes to such things as curriculum, culturally relevant curriculum, retention and recruitment of Black educators. That is one of the very, very intentional things that we are currently working on right now. So I'll talk a little bit about the charge and the mandates that are for K-12. And again, this will be a high-level overview just to kind of put us back on time. And so overall, every person that works in public schools throughout New Mexico are charged with making sure that they understand the importance of House Bill 43, which is the Black Education Act, in preventing and directly addressing school-based racism, bias, and other sorts of exclusionary acts that happen in schools. One of the other things that the Act requires is every year, November 30th, every year, every school district must create discipline policies and submit that language to us. And embodied in that, in those policies, they have to show us that they have provided opportunities for the students, staff, as well as community and family members to have input into these policies. With regards to Black education, the very specific terminology that must be present that we look for is how they define racialized aggression. That must be very clearly defined and articulated in how they are going to deal with that. If those things are not present, then we send it back as being non-compliant. We also try to make sure that we remove barriers of compliance with the Black Education Act. And so we, every August, host a virtual series that's called School Support Series, so that everybody can understand what exactly these requirements are and how to fulfill them. And we want to give a special thank you to Dr. Martin, who in the development of the Act was, of course, our health professional that very clearly articulated some things that he thought was very important to include in this. And when the final Act came back, the one thing that stuck was the students' rights to self-administer asthma medication. And as we know, I know I'm preaching to the choir here, but you know, students miss a lot of school because of underlying things like asthma and not being able to take, you know, do their own inhaler that has been prescribed to them. And so they're missing school. It's very oddly positioned in the discipline policies, but sometimes it's also listed within the health policies of the district. Michael, if you could talk about very quickly the requirement for the anti-racism training.
Yeah, good afternoon, everyone. So again, my name is Michael Beatty, serving as the Professional Learning Coordinator for the Black Education Act. In this role, primarily, one of the main things that I do is go from school to school and provide them with these anti-racism trainings. These can be given in or by way of the Meeting the Moment training that we have on Canvas, which is essentially a different type of way to have some conversations about race and ethnicity in the classroom. Along with that, we also do a thing called a culture chat. We'll have teachers devise some different questions that they have, and then we'll actually have a conversation about those questions, whether those be things about their specific classrooms or things just about the school environment and some different things that they would like to adjust and change. So it's been nice to have some positive conversations about that information so far.
Oh, you're muted. Thank you.
Sorry about that. Thank you. I'll talk very briefly about the anti-racism portal, but I just wanted to piggyback off of what Michael was explaining about the meeting the moment. When the Black Education Act was first rolled out, we understood that there were some school districts that had resources that could fulfill these trainings, but the premise was that we wanted to remove the barriers from being able to comply. And so the Black Education team has created a 3-year module course that fulfills the requirements for this every single year. And I want to proudly say that to date, nearly 5,000 educators have completed this. It is only one of the many opportunities, training, anti-racism opportunities that they do have, but we are very intentional to make sure that any training, when we used to have, it used to be called Safe and Healthy Schools, that was maybe about 15 minutes. And we said, no, we want to make sure that it is high quality because we understand very clearly that racism is multi-layered and we want to take it very seriously. And so we do vet every training and every vendor that wants to provide this training. Another thing that I think that is important to share with you about this is that with the culture chats, one of the things, I used to be a school counselor, I'm a licensed mental health professional, and one of the things that I very clearly understand when it comes to racism is that we take for granted that our educators, especially in pre-K through 12, know how to have these conversations, are aware of their own biases. And so our goal is to provide safe spaces where they can submit anonymous questions for us to talk about so that we can create these spaces so that people can no longer have excuses about they don't know what to say or they don't understand how to operate. So we try to provide those spaces. And so there is a one line in the act that talks about this anti-racism and anti-oppression portal. And it just simply says that there must be a statewide line that racism, school-based racism can be reported to, and that was it. And so what we have developed, what went from being a very manual, us answering the phones and, you know, jotting down information, we have now created a very comprehensive online digital platform. Some of the things that we are trying to make sure that we can do is to protect the students, the parents, these educators, anyone that is working with students and either experience or witness school-based racism, that they have a safe space to report those things. Right now, that is not covered. It is not protected from IPRA kinds of things. And so we are working very carefully to make sure that this well-intentioned portal is safe and serving in the best way. So right now, the way that this operates is we can use this QR code, but we want to make sure that everyone knows that they can make these referrals. And we serve as a neutral party, unlike what a lot of people think. We do not have investigative authority. And so our role in this is that when a referral is made, we determine whether or not it is school-based racism. For instance, if it is something that takes place during intramural sports during the summer, unfortunately, that does not qualify as school-based activity. And so we, if the person gives us permission to talk to the school district, we, you know, collect all of the information, try to serve as a conduit to try to help people understand and be heard by each other, but also to remedy the underlying issues that are at hand and to try to prevent those things. And so that may look like us going out after we have met with everyone. It may look like us going to do some more trainings with the staff that are involved. It may also may mean, and I have done this many of times, going out to do a training or a workshop or some type of empathy support for students on the ground. So we are going above and beyond just checking the boxes.
Kimberly, we had a question from somebody in the audience, and so I just want to ask that question and then give you guys like 2 more minutes. But the question is this effort connected with the New Mexico Community Schools effort at PED? Does that
Yes,
sound?
we are all under the same umbrella. And so if issues happen, we also serve charter as well as community schools. And so when things happen, we want to make sure that we are connecting with the appropriate, if it's us that needs to handle it, we'll take care of it. If it's a situation that involves special education, they have their own bureau that will handle those type of complaints. But again, we work very cohesively with all of the other acts. And so if there's a situation that falls outside of our reach, then we make sure we connect them with the appropriate party. So I hope I answered your question. Yeah. Okay. So just two more quick slides, really, really quickly. So we also are charged with making sure that there is culturally relevant curriculum in our classrooms. And so Joseph, who is our curriculum coordinator, works very diligently to create those type of resources. And again, we work very highly with higher education in doing that as well. Joseph is right now undergoing leading a task force, a Black History task force. So we'll talk about that a little bit later. Okay, and then parents, we work with parents to make sure that they have a place where decisions are made, and we're trying to make sure that they have opportunities to have leadership and be more involved with stakeholders regarding their child's education. And then lastly, we definitely work with higher education, which is a lot of you here. And so I know that UNM has a robust Africana Studies program, and New Mexico State is getting underway. We have a course there, but we want to make sure that we are also tapping into those historians that have been trailblazers in New Mexico. And so we're going to be working on developing a New Mexico book that features Black historians that have made major contributions, not only in New Mexico, but also throughout the world. We do have monthly advisory council meetings, and those are publicized on our website. It's always the second Saturday of the month, and so I invite you all to join us. We also have a Black Education Act conference. This will be our third year, and so you can reach out to us and we can provide you with more information. Thank you again.
Thank you very much. I feel like we should have Joseph just say something because he was there. Joseph, is there one final closing message you want to give us in the name of equity? I feel like we should have Joseph say something because he's there. He showed up.
Thank you, Kimberly, for just providing all the information. Right now, we just have three big initiatives that we're working on for curriculum, and that Black History Task Force is we're working with OER. So we're going to be implementing some open educational resource and microsite at our state level that will be coming soon. We're also supporting AP African American Studies teachers at the K through 12 level. As some of you know, the pilot programs were this year. Next year, we're going to be opening up statewide. And our third thing is we'll be opening up a Black Teacher Pipeline initiative. And so we're in the initial discussion phase where we're working with some higher education institutions on that. So we're really happy to and excited for these ventures. Thank you.
Dr. Joseph.
Excuse me. Thank you for that insightful presentation. We know that, of course, education is quintessential, right, in improving health outcomes. So thank you for all the work that you do and for your presentation today. Okay, so next we're going to transition to uplifting the health and wellness of BIPOC communities in New Mexico with a closer look at Black women, birthing people, and maternal and infant health and wellness. This is a presentation that will be led by Mrs. Lakeisha Cotton, Danielle Miller, and Nicole Morris.
Hello, hello. Thank you for having us be a part of this important conversation. As many of you have said on this panel, we understand that healthcare in this society was never meant for us. We were not meant to survive in this system, let alone thrive. And so the work we do here at Black Health in Mexico is in reimagining that reality by centering Black futures through policy change, culture shift, and providing direct services. So that's what we're going to talk to you all about. We're going to keep it brief, and we're going to stick to the clock. We are an all Black women-led organization that works towards uplifting the health and wellness of Black communities, period, in New Mexico, alongside Indigenous communities and other folks of color. And we approach our work in many different ways. But 4 principles that really root us and guide us are community building with intention, utilizing a liberatory framework rooted in the history of traditional Black social justice movements. That's key. Forging solidarity and deep alliances with our Indigenous relatives, and resisting patriarchy. That's the 4 pillars that kind of move and guide us, along with other intersectional points that keep our work flowing. And I'm going to pass it off to you, Danielle. You're looking like your name is Nicole Morris, but you're Danielle.
I know, I just noticed that, so I'll change that in a little bit. But I first of all, I just want to thank everybody for joining us and for putting this event on. This is, of course, extremely important. I am a midwife and a psychiatric nurse practitioner here in Albuquerque in New Mexico, and also a mother first and foremost. And so that is the work in which moves me to do this work, right? So my children and my community. And what we know is that in New Mexico, Black babies have the highest ratio of premature birth and infant mortality. Black women have traditionally experienced the highest rates of maternal mortality, second to our Indigenous relatives. And nationally, for us, Black women have the highest rates of maternal mortality. It's such a hard word to say right back to back. Maternal mortality in this country, and are wholly responsible for the Black maternal health movement, which in turn put this movement on the front page of the New York Times. That also released billions of dollars into our communities. Well, not really into our communities, but into the country anyway, to addressing the maternal health outcomes in this United States that we have. So the way in which Black Health in New Mexico has went about, and Nicole and I specifically, and Lakeisha will jump in too, has went about addressing this is many ways. And so I'm going to let Lakeisha speak a little bit, and then we'll sort of pop back in, myself, Nicole, about some of the direct service that we do and some of the policy and coalition work that we do that helps uplift our communities.
Good afternoon, evening, everyone. Good to be here. Good to be here with you all. My name is Lakeisha Cotton, and I am a public health advocate. I develop and facilitate training surrounding topics surrounding diversity, equity, and inclusion and justice, with an emphasis on health equity. So really grateful to be here supporting Black Health New Mexico's initiatives and to be with you all today. So yeah, just want to say, this is why we're here. We are the people that are impacted, right? We are the people who are being impacted. We are not the outsiders looking in, right? We are the people who are being impacted. So it's really important that we are the people who are doing the work, are the voices behind the work, the engine behind the work, because we are the people who are being impacted. So just keeping that in mind as to why we are here, why we are doing the work together, is because we are the people who are being impacted.
Yeah, thanks, Lakeisha. And, so I'd like to share a little bit about some of the programming and some of the things that we do that includes our direct service work. One of the things is we have a group of community health workers, and our focus is on perinatal mental health. So we help, I don't like to say train, because people come with their own expertise. So we highlight and uplift and strengthen their expertise so that we can go into our communities and care for folks alongside them, with them, not for them. And we do everything from talk about, how to care for your baby, talk about the postpartum period, talk about the pregnancy, and support them both in their mental health journey, as well as the needs that they have that they're not getting through their providers in the community. We also work in doing coalition work across cultures. We do a lot in solidarity with our Indigenous communities because we are really side by side so often in many of these systems that do not serve us or are serving us the way in which they were formed and created to serve us. So that coalition work does many things, works on policy for making sure that we are serving our communities the way they want to be served, not the way that the system wants to serve them. So one thing that we know is that we have the answers in our communities for what health looks like and what we need and what we want to move and live in a healthier way. And so because, as Lakeisha mentioned, we are those communities and those people, we also know that. And so we're able to, you know, work with our communities and within our communities to get the things that they want us to support and help and move forward those initiatives. And so that's what we do. And then I'll let Nikki or Nicole talk about some of the things that she does while I change my name.
Thank you, Donnie. Yeah, so one of the things that I really love to talk about when I talk about Black Health New Mexico comes from my experience moving to New Mexico from Oakland, California, from LA, but we moved our sons out to New Mexico to finish their schooling. My two sons are grown now, but they went through middle schools and high schools in Santa Fe, where we saw firsthand the space we occupy out here in New Mexico. We occupy these two spaces of being hypervisible and invisible, right? And we've talked a little bit today about how our numbers are so small and it feels like there's none of us out here, but we are out here. And at Black Health New Mexico, one of the most beautiful, one of the most gratifying works that I've been able to be a part of is providing direct services through deep community work. We have had we just started a postpartum healing circle for BIPOC folks, birthing folks and women to come together in that period of time after you have a baby, when you already feel alone and you feel extra alone when you have these other impacts on you, right? Your race, your class, isolation. We ran a young parents program where we had BIPOC young parents come together to just vibe and just talk about what it's like to be a young parent, to be a young Indigenous parent, a Black parent, an immigrant parent. Donnie and I did a sex ed across the lifespan focus group with Black women going over how our sexuality changes and grows and develops and morphs. And that was a powerful space just to hold. What am I forgetting out here, Donnie?
Yeah, I mean, I think that's a lot of it. And one of the things that I think is crucial to the work that we do, and I think, Nicole, you mentioned it in the beginning, is really that all of our work is really through a Black feminist lens and a liberation framework. All of the work we do. When we are working across cultures, same, right? It has to be the same. It has to be that, because that is what our communities need, deserve, and that's really the only way to true healing and wellness, right? We can't use these systems that exist to think that they're going to care for us in ways in which we deserve and need to be cared for. We have to create new systems alongside our communities and with our communities. I think, one of the things I think that's brilliant and beautiful and so magical about our community health workers, that they are all BIPOC people, Black and Indigenous people, and they are all trained doulas. So they are both postpartum and prenatal doulas. So they have that training and that experience as well. And are able to just meet so many of these needs of our community members. Another thing that we've done, because we also know that we are whole people, right? So health, we see health as a wholeness, right? Not just pieces. And so we've also had a farm to table program where we grow the food and then bring the food to the community. We really highlight and lift up our elders in the community, because those are the ones that continue to teach us and help us grow into leaders and parents and better community members. So really supporting those folks in our community too, that have that wisdom that they're able to pass on to us, and then that allows us also to give back to them, right? So that we can keep that circle going. Yeah, I think that's anything else I'm missing, y'all. We are busy people. We are
I would
busy
just-
people. And what I love about this work is we do everything from policy to direct service. And as a midwife and a psych MP, it's crucial to me to also be literally directly involved with the folks that are in our community and helping them find the things that they don't get from these institutions, right? To help them improve and grow their health.
So I would just like to thank you all for the presentation. And one of the things that I've been most impressed with your organization is that not only do you provide services, but you engage in systems and policy change. And so you've done a lot of work in that area, which is crucial to increasing opportunities and resources for women of color in New Mexico. So again, everything from service to systems change, it's a complete operation. And so we just want to thank you very much. If there's a way to contact you all or a website, can you put it in the chat?
I did.
And, oh, great. Okay, thank you. And Dr. Joseph, I'm going to turn it over to you.
Okay, thank you so much. That was a wonderful presentation. It's great to hear about the work that's being done in the state to improve these outcomes. Thank you so much. I'll say to Mrs. Nicole Morris, I like that term, hypervisible and invisible, and also including the framework in which you do your work. So one of my students is in the audience. I'm going to mention now that that's a framework we're going to start incorporating. So thank you for bringing that up. So for the sake of time, I'm gonna move on next and introduce someone who likely also doesn't need any introductions for the work that they are known for. I'd say both, well, definitely in the state of New Mexico and abroad. And I'd like to introduce Dr. Stephanie McIver. She's the Executive Director for UNM Student Health and Counseling. Her presentation is titled State of Black Collegiate Mental Health at UNM and Beyond. And you may recognize that name from the film. So it's my great pleasure, my esteemed pleasure to introduce Dr. McIver.
Hi. So yeah, I was really thrilled to see that's my dad, who was a physician in the state. So I was raised in the healthcare community here, returned to New Mexico and very interested in healthcare. I, however, am a clinical psychologist and that's my pathway. I currently direct student health here at the University of New Mexico. And from this vantage point, have a particular interest in Black student mental health. So I'm going to talk a little bit about that. I want you to know where we get our data. I'm going to talk a little bit about national data and our UNM data that I think is important and really demonstrate sort of some of the things that all of my colleagues were talking about today, that our health is a function of place. And that's evident in the mental health of the Black students that we serve. I'm putting a few links, so I want you to catch them from the slides of things that I'd like you to look up. So this is our Black Minds Matter course, and our students here at UNM and KUNM did an article about them and talking about what that course is about. And so please look that up on your own time too. I get my data, the national data about collegiate mental health from a study called the Healthy Minds Study. And it's a study that goes out to every collegiate health service every year. So this is a mix of 21 and 22 data. But in the most recent data collection of all the colleges and universities that they survey, over 300, there were approximately 12,224 Black students in the most recent data set. And I think that's really interesting. A small percentage of the overall, 16%, but a good representation. And one of the reasons why I think collegiate mental health is a really important group to study is it's because it's these key years where we begin to see significant mental health issues, especially mental health disorders, arise. So we start to see that in 17 years of age and up. And so we see a significant number of our students having some mental health issues, and increasingly over the last few years. So the Healthy Minds Study indicated that from their 2013 study until their 22 study, there's a 135% increase in depression. Although depression is not the key issue that we are observing in our students in general, but our Black students in particular. There's a 110% increase in anxiety over this period of time. And anxiety is a hallmark mental health issue of this time. And we all can surmise what all the societal reasons are about that. A number of students who meet the criteria for a mental health disorder, a diagnosis, doubled during this period of time. But one of the things that related and cited studies have found is that depressive symptoms, for one, tend to be more persistent, more disabling, more troubling for Black students and Black people in general than their white counterparts. And one of the things that we study about Black Americans is, and that we see, is that we're less likely to seek treatment for a whole host of reasons. There are 8 or 10 reasons that are commonly cited, one of which is economic inability to seek treatment. If we're going to choose where we're going to put our meager funds, it's not going to be in psychotherapy or psychiatry. And so people don't seek treatment. We also are not covered under insurance at the same rate that white Americans are, but there are also some cultural and familial belief systems and attitudes that keep us from reaching out for help, even when we know that we need it. So another problem that I know Donnie, who's a PNP, and there's another counselor in the group, a licensed therapist, we're not represented in the field very highly at all. So your ability to find a Black clinician, if you feel connected to, like you need to connect on that variable with your therapist, is very difficult to find. So only 5% of psychologists across the whole nation are Black. PNPs, the psychiatric nurse practitioners, that percentage is even smaller. So very hard for Black folks to find clinicians that they feel like they can relate with. But there's another important variable that's being elevated in the literature and in our social media, and it's about Black men in particular, as being particularly resistant to psychotherapy. And so there are a lot of initiatives that are developing to try to tap Black men where they most likely engage. And I do know that the Black History Council has an initiative with Black barbershops here in New Mexico. But I want to direct your attention to Dr. Earl Turner, who is a leader in the American Psychological Association, has a podcast where he talks about Black men in particular and mental health and psychotherapy. But there's a particularly compelling piece. It's on NPR. So if you go to NPR, this link on the bottom, and just look for Black men and barriers, this really terrific show comes up, this news article about Black men in psychotherapy. And I pay attention to Black men in psychotherapy here at UNM because we do know that there are incidents and events that occur on campus that indicate the distress of that particular population, and yet they do not seek psychotherapy or really many of the other supportive groups that are on campus that are available to them. So that's of concern, how to reach that group. Here at UNM, I looked into our own data. My other set of data is here at our health service and the electronic health record from which we kind of pull data about the students that we see. So we looked at the data in 2023 from January to December, and we noted that there were 600 individual encounters with Black students here on campus, which is not significant, and that does not represent individual students. There were, in fact, at this time, less than 600 Black students across the entire campus, undergrad and grad. This is 600 individual encounters, and that has to do with the model of service where students can drop in when they need to drop in and come back when they need to come back. There are a few that are in consistent course of therapy, and some of those are the outliers. There are only a few Black students in our service. So I kind of manually tried to glean, okay, how many individual students does this represent? And it's only about 7 male students and 16 female students using about 600 encounters in psychotherapy. That's not a lot. That's a terrible rate. And so we're trying to figure out what to do. Consequently, I run a psychotherapy group through African American Student Services, which is all female, even though it was advertised as co-ed. And it's been a terrific encounter with the women that I work with, and very needed and necessary, but we need to think about what to do to connect with Black men in their areas of need and growth. The data, those 600 encounters with students, represent primarily anxiety disorders. These are the diagnoses at each of those encounters for our students. So if you look, depressive disorders, which are kind of 2/3 of the way down the page, there were 22 encounters where students met that criteria, and depression unspecified, and then down further, 16 encounters where major depressive episodes were experienced. But the majority of it is anxiety disorders. And I talk to students every day. They are so conscious of their place in this world, or feeling lack of place in this world, the sense of danger from encroaching social and political and dangers and threats, and also to their future. And so anxiety is presented pretty strongly. This is a list of resources around psychotherapy and mental health for Black people that I really like, that I think are really great. And I can make this set available to you all if you want that, so you can look up these links on your own. And then these are the resources that we direct our students to: student health for students across the board, counseling assistance and referral services primarily for faculty and staff, but a lot of our students are also staff. And then NAMI has a particularly terrific page keeping track of the mental health and the data for Black Americans and the issues that pertain to Black Americans. And then again, always touting African American Student Services, who I've been in alliance with and producing outreach and psychotherapy programs with for all the years that I've been here at UNM. So very appreciative of their support of Black students. And I'll end there.
Thank you very much, Dr. McIver. We're going to move to our last presentation, but for those of you that have stuck with us and have been following along, we hope that you see that this is a journey from understanding the foundations of Black health and the outcomes that we see in our clinics, in our public health system, in our hospitals. So we see the foundations from the Africana panel, and then we move to these kinds of outcomes on Black mental health. And now we're going to see another outcome, which is the affordable housing gap in New Mexico for African Americans. So Dr. Joseph, who's up next?
So yes, up next we have the state of housing for African Americans, Sanja Unra. So I'm sorry if I mispronounced your name. And they'll be coming to us, talking to us about the state of housing for African Americans and the housing gaps.
Thank you so much for inviting me to join this panel today. My name is Sonia Unrau, and I work with the New Mexico Mortgage Finance Authority. We do all things affordable housing for New Mexico. And I'm wondering, I don't use Zoom often. Can you see the slides that I've got presented?
Yes.
Okay.
Yes, you're not in the presenter mode though.
Okay. Here we go.
Okay, there we go.
So in 2022, we commissioned a New Mexico housing strategy, and this was an effort to create a holistic view of the state of housing in New Mexico, and we did dig into race and ethnicity as far as gaps there. So that's really where this data is drawing from. As part of this effort, we also administered a resident survey to get really a sense of what's going on from a household level to bolster these needs. And this survey, while not representative of maybe New Mexico as a whole, really was able to reach some of our most vulnerable residents. These include people that sought assistance during COVID, and those living in public housing, and also who have sought services for other financial needs. And we also spoke with many industry experts to come up with a list of strategies. Cost burden is probably one of the most common metrics of housing needs, and it's severe cost burden is when a household pays more than 50% of their income towards rent, and cost burden is between 30 and 50%. Not only do African Americans in New Mexico experience cost burden generally higher than other groups, they experience severe cost burden significantly higher. And part of the untold story, I think, of housing needs is households doubling up. And that is basically living with friends or family because you can't find anywhere else to live. And based on data on overcrowding, Black and African Americans residents experience overcrowding at a rate of 22%. We also looked at the need to preserve existing housing. In many areas of the states, we're not growing, so we need to reinvest in those areas. Overall, our state has 43% of our state's housing stock is aging. And when we ask people to rate their conditions of housing, Black and African Americans at a rate of nearly 20% to categorize their homes as fair or poor. And this was the lowest, I guess, most severe option for assessing the housing condition of their home. When we look at home ownership rate, New Mexico as a whole does better than the nation. However, gaps in home ownership by race and ethnicity are extremely pronounced. Whereas non-Hispanic whites are able to own homes at a rate of 72%, Black and African American households are just below 50%. And this is in part due to lower income, but we do know there's many historical reasons behind that as well, including lending discrimination and redlining in housing. When we sought to dig into barriers of home ownership, bad credit and low credit score was among the top barriers, in addition to having too much debt to qualify for a mortgage, and pretty close was coming up with a down payment assistance to buy a home. Our homelessness is growing in New Mexico, and it's really upsetting to see that while African Americans account for less than 3% of the population, they comprise more than 10% of our homeless households. In our resident survey, we asked respondents to speak to if they had experienced displacement, the reason behind displacement. For the Black and African American respondents, increase in rent was the primary reason, but following closely was either just losing their home because the landlord wanted to do something else with it, being forced out for no reason, apartment rules, and legal eviction. And when we think about how to move the needle on these housing issues, it has to be holistic. We have to address needs from homelessness to home ownership. And one thing that has been discussed nationally is how to address the supply challenges. We try to provide down payment assistance, housing choice vouchers, but at this point, we're really seeing limited number of units being a concerning constraint to opportunity. One example in New Mexico might look towards is actually the state of Montana, who passed legislation in 2023 that to comprehensively address regulatory barriers to housing supply. And this was primarily through repealing exclusionary zoning that has roots in discrimination. And they did so by, for example, allowing duplexes in single family neighborhoods, allowing by right permitting for accessory dwelling units or casitas, and also guaranteeing permitting for multifamily or apartment buildings in commercial zones. And with that, I'm happy to take any questions. I realize this was brief, but.
Thank you so much. I think that was just enough to get us started on this complex issue. You and I had a conversation about a good example of a place where they were addressing issues of NIMBY, because when you try to build affordable housing in different places, you encounter pushback from the community. And we selected a place. What was that place that we discussed?
Montana. And really, they were able to address NIMBYism, which is not in my backyardism, through these regulatory reforms to zoning that basically permitted or prohibited communities from protesting, for example, an apartment building being constructed. They said, because this is a commercial zone, you're allowed to build multifamily. So there's not really an opportunity for the NIMBYs to obstruct the development. I think it's really, we've seen cities move towards this, including the city of Albuquerque, but there's a long way to go in making sure that this is the case throughout the state. Las Cruces has also been an example of an area in New Mexico where the local government has just put so much resources to housing and highlighted it as an investment priority for their community, that they're among the leaders in the state for developing affordable housing, and they've created a culture of positivity around it and tying it to economic development and family stability that I think has really reduced the NIMBYism.
Thank you so much. I think the simplest way to say this is that it's hard to be well, even if you're taking drugs. If you don't have affordable housing, you encounter racism, and you don't have stability in your job, and some of the other factors that we've looked at throughout this event. So Dr. Joseph, you had some other information you wanted to share with us, and then we're going to close it out.
Yes, give me 1 second.
Can you find yours? I have mine pulled up.
Yes, and now it's being a little slow for me now. Do you mind pulling it up?
Yeah, I know. Let me do this really quickly. So first, I'm just going to take a minute to plug our next 2 events if you have not registered. So in March, we are looking at neurodiversity and accessibility in higher education, and we have a renowned national speaker coming to visit with us, and that's on March 22nd. And then we have Hispanic and Latinx issues and Spanish language in April. So please take a minute to register for those events. And then we have one final event that is coming out of the Office of Diversity at UNM. And I just want to plug this issue for Dr. Valerie Romero Leggett, and this is about everybody should know the story of Henrietta Lacks and her cells and their impact on cancer research. But there is a speaker that is coming on Tuesday, March 5th, as well as another reception on March 6th. So that event will be happening in the next 2 weeks. Thank you so much.
Dr. Andres, one second,
Yes.
I was just going to say both of those convenings, thank you so much. Both of those presentations are open to community. There are 2 presentations by renowned scholar, Professor Alford, who was here before, and actually several of our members who are here have heard this very dynamic speaker. And, you know, as Dr. Powers was talking about reparations and everything, this and her seminal work in unjust enrichment really made a huge difference in the most recent case now, where the family is finally receiving remuneration for what was taken from Henrietta Lacks. So I think amazing dynamic speaker, and I would hope that people will be able to join. And unfortunately, this will be only in person. We won't be able to do a recording or a Zoom of it, but again, one's in the day, which is harder to get to, we know, but one is an evening event as well, with partnership with School of Law, Algorithmic Justice, Equity and Inclusion, and African American Student Services. So thank you for giving time for being able to share that, and we'll get that out to the community and to share the flyer as well.
Thank you very much for sticking with us. We really appreciate it. And Dr. Joseph, do you have any closing comments for us?
Yes, so in short, because we are over time, I'd like to first and foremost thank our presenters today for the wealth of information that they shared with us. We see a lot of implementation work that's being done We see a lot of room for improvement as well, highlighting some of the issues, many of the issues as well. Again, being hyper-visible and invisible at the same time presents a wealth of challenges for all of us to work on. So I'm really excited actually to be here at UNM, at the HSC, to really be on the front lines of improving health in New Mexico. So again, thank you to all the presenters. Also, I want to say thank you to everybody who attended as well, even those who couldn't stick around to the very end. I appreciate your time and your attention. Also, I feel like I really need to say thank you to Nikki as well for running the tech support behind the scenes as well. So again, thank you for all of your support. We're very thankful to have you all here today to partake in this one of many convenings to come. So with that, I will say thank you and enjoy the rest of your evenings.